Hello, I'm Dr. Ron Riner, and I have the privilege and pleasure of having as my guest today Dr. Eric Rackow. Dr. Rackow has a prestigious medical history and medical background. He was the chairman of the Department of Medicine at St. Vincent's Hospital in New York City. He's been the chief medical officer of New York University Hospital Center and president and chief executive officer of New York University Hospital Center. He is currently president and chief executive officer of Senior Bridge. Eric, welcome.
Thank you very much. Pleasure to be here.
Eric, how did you make that transition? Let's start by talking.
Well, that's a very interesting question. So, Ron, I grew up in hospitals, so to speak. I worked in hospitals for over 35 years, actually my whole career, except for the last 3 years that I've been at Senior Bridge. And I'm actually a critical care specialist. Started my career in taking care of the sickest patients in the intensive care units, and grew up in that for many years in terms of my interest in clinical medicine. And one of the things I learned during my time is that it's very obvious many of the patients in the ICU are older people with chronic illness. And they have acute exacerbations of the illness, and they come in and out of the hospital and the ICU. It's a frequent flyers, some people call it. Right. And I got interested in chronic care. And as I became, as you mentioned, the chairman of medicine, a chief medical officer, and then president of a hospital, as hospital president, we had a very big problem at NYU in taking care of people with chronic illness, again, because when they left the hospital, the coordination of care outside of the hospital was not sufficient, and we'd find them coming back in. So when I stepped down as president of the hospital, I decided to do something a little different and decided to try and help solve the problem of caring for the chronically ill, and joined Senior Bridge, which is a company that is about 10 years old and had developed a very interesting model for doing just that.
Talk to me a little bit about this model that Senior Bridge has.
So Senior Bridge is a company that was founded in year 2000. It was founded as a company that would take care of older people at home, initially providing home health aides in order to support them at home because they needed assistance with their daily activities. But rapidly recognized that a real issue was that the older people we were caring for had chronic illness, and they needed more than just caregivers in the home, whether they be family caregivers or home health aides. They really needed to have their care coordinated in terms of making sure their chronic illness was maintained in the best possible condition and they functioned well. And the company added care management. And that's the core value of the company. And what I mean by care management is the utilization of professionals, licensed nurses and social workers, who go into the home and understand the patient, the family support, the environment, and enable someone to be able to maintain their health and their functioning to their best possible capacity by coordinating all of the issues that make somebody well.
Well, I think you've made a very novel move from the acute care, complex environment of intensive care units to heading up really an outpatient-focused endeavor.
Right.
Let's explore that a little bit. Let's explore the environment you're currently working in. Talk to us a little bit about your view of aging in place. This is a concept that a lot of people are talking about. What does aging in place mean to you?
Aging in place is a very, very important issue. To be able to grow older in the comfort of your home, both in the sense that you have the appropriate physical environment, the community support services, the assistance you need with your activities, if your functioning changes, and in fact to have your health maintained at home rather than having to go to a hospital or emergency room.
Well, when you look at that concept, it has great merit. As you and I both know as physicians and having dealt with people in different environments, there's the old adage that aging is not an age, not a number, but an attitude. Right. So how old is old?
I think aging is a lifelong spectrum of growth. I think that when you reach age 55, prior to retirement, if age 65 is sort of a focal point of retirement, although that's changing also actually, when you're a more mature adult, you ought to start thinking about aging in place and what do you have to put in place when you reach 65 or 70 or 75. And, you know, retirement actually has been pushed back. You find so many people working past 65 into their 70s, and it's certainly true of our national leaders. They're often running for president at an older age.
A lot of people don't realize that William Mayo started the Mayo Clinic at the age of 70.
Right.
So
experience counts.
Yeah, I hope that's the case. I hope that's the case for all our sake. You know, there's a saying that as you face retirement or your maturing age, you need three things: someone to love, something to do, and something to look forward to. Let's explore those a little bit. This whole issue of companionship, people age, they go through changes in their lives, they move away from family. You mentioned that 10 or 20% may move, but some stay in their communities. How do you, from your vantage point, or how do you and your organization help people chart those waters? Let's start with who do you love, someone to love, companionship. How do you deal with that?
We look at it as a process of socialization would be one way to put that. We want to make sure that the older adults we care for have an opportunity for socialization. So our care managers, part of their role is to make sure that the client that we care for can go out, can meet people, go to functions, and to have a relationship with people and help them navigate those waters if they need to be helped. So I think it's a very, very important issue for people as they grow older. We ought to be developing more environments where that can occur, like Pelican Bay, for example, where people can be in a planned community, can be in a senior adult community, and can therefore be with people of their age and of their interest and meet people and socialize and have companionship.
Let's go to the other something to do.
So I've been having this discussion with my wife. What should we plan for our retirement? And she would say to me, you're not going to retire because you would have nothing to do. So to retiring at 65 or retiring at 67 or whatever age people talk about, I mean, I don't think we should look at it that way. We should look at continuing to work and be active if that's what we'd like to do. So, and I think putting that in context, organizations, employers understand that, and people are allowed to work for as long as they like and are valued because of their experience. Look at part-time employment, look at volunteering, look at volunteering with being paid. So there are a number of organizations that, you know, take the experience and use that to go to companies and say, we have a very senior person and they would like to work part-time, maybe on an hourly basis, and almost like you would hire a temp service, be able to hire senior people with experience and pay them on an hourly or a part-time basis. And I think there are lots of ways for older adults who want to enjoy a bit of retirement but still want to be active to find work, to make themselves available, to offer experience to others, including volunteering. So I think there are all kinds of ways to figure out how to stay active.
That's great. You know, let me pick up on something that you said. You're talking with your wife, and you're looking at the future. You know, if you had to give our audience a recommendation, what would it be the best way that you think you could prepare for your mature future? You know, as you look to that future, how do you prepare for it? What's the best way?
Right. So I think that it depends who you are, but it's important to begin to plan for your older years, both your health, because that, as we all know, and we'll talk about that a bit, is very important. It's one of the things you mentioned. Your financial well-being, your socialization, the environment you want to live in. So I think it's important to start to think about that. Sometimes those things are hard to figure out because it's not within your area of expertise, so I think it's helpful to have an advisor. Those advisors can be a financial advisor, an elder lawyer. In our case, we think we're pretty good as care managers advising people and being their advocate for what they should have. And so a whole field of geriatric care management has grown up in this country, and the National Association of Professional Geriatric Care Managers is a place that you can go to find such advisors or advocates in any part of the country.
Dr. Rackow, let me switch gears here just a little bit and take you up on some of the environmental issues that you experience in dealing with people in an outpatient setting. Your business model is that you try to keep people in their home setting and their common environs. One of the things that many see is a natural reluctance on the part of people to have other people come into their homes. How do you deal with that?
One way that I think is successful is first to use a care manager who's a licensed professional who might come in as an advisor, as an advocate. And so that usually goes over pretty well. People would accept that, a professional visit, just like you went to a doctor or a lawyer to talk about planning your future. And then another way is to have if somebody needs support, needs caregiving, and a family caregiver. By the way, the majority of caregivers in this country are family caregivers, members of the family taking care of their parents or loved one. But if a family caregiver is not able to do that, to have somebody come in initially just to maybe just for an hour, just to cook on a day, or go shopping with the person and make sure there's food in the house, so that you introduce that slowly as, not somebody who's going to live in your home, but here just like you would have somebody come and do a repair to your air conditioner or give you advice. And so if you do that gently over time, I think people adjust to that. It's interesting, the care managers become the surrogate family. Many older adults, as in the case of my mom, the adult children live distant. About 40% of those that we care for have their children living distant from them. So the care manager becomes the surrogate son or daughter. They relate to them as if they were part of the family. And once that happens, then that person is able to bring, if they need a home health aide for caregiving in the home, to introduce that stepwise. And I think that works many times.
Listening to you talk, a growing concept in medical practice is group office visits, where people who have certain illnesses or disease processes meet as a group to talk with the doctor. Does that apply at all in the aging in place, or in your concept where your care manager would have a group meeting of different people or visit in group at different people's homes? Does that concept apply?
That does apply. We actually haven't done that yet, but we're actually just to the point of considering that, and especially for socialization and for diseases where there are common issues, that instead of doing things one-on-one, if you bring people together and perhaps get them out of the house and perhaps come to the office for a meeting and have a group educational session, usually is what we would call them.
At the time of this filming, we're very a short distance after the signing of the health reform bill. And if you look into the future, and we say in 2030, short 15 years from now, we're going to have over 71 million people or so that'll be over the age of 65. Currently, we have about 35 to 40 million. What does that health reform bill have as it relates to the aging of the population?
So that's a very important question, and that has been such a difficult debate over the past year to understand what health care reform means for those people that will be affected by it, which is really pretty much everybody in the country. It begins to tackle the long-term issues we have to deal with in terms of how are we going to deal with our health, have universal coverage, and care for our seniors in a way that provides the best health care, maintains their function, and the country can afford to fund that kind of health care. My view of the legislation is that it does set in motion an approach to health care with universal coverage, with insurance industry regulation concerning pre-existing conditions and cap on lifetime benefits, and tackling the issue for Medicare of how are we going to make Medicare solvent. So seniors are dependent on Medicare, which comes out of the Johnson administration in the 60s. In those days, there was no ambulatory chronic care. That was an acute care health program, right? It's an acute care health system built around hospitals. And today, as you know, and as we've been talking, people are aging, and as they grow older, they develop more chronic conditions, more chronic illnesses. And as that occurs, the approach to healthcare has to shift. The paradigm has to move from acute care to chronic care, from episodic care to continuous care, from in-hospital facility care to at-home out-of-hospital care. And I think the health reform legislation does begin to tackle that issue. When the president or when the newscasters talk about we have to save money in Medicare and Medicaid to fund the uninsured, people think, oh, gee, well, they're going to take my health care away. But I don't think that's true. I think what's in that bill, and my interpretation of it, is that there is innovation center, research center, demonstration projects, forming an independent Medicare council to recommend changes in Medicare, which are aimed at not denying health benefits, but changing the paradigm, shifting the paradigm to how do we care for people out of the hospital and at home. So this is what Senior Bridge does, and I think that when Medicare grapples with this, and when the country grapples with it, we'll find that we can take care of people at home. We can reduce their visits to emergency rooms. We can reduce their hospitalization rate. We can maintain their health and function. And if we were able to do that, then you would save cost. So I believe you can improve health care for seniors, yet at the same time save cost if you do it outside the hospital and coordinate their care in a way that avoids unnecessary hospitalization.
You know, part of that legislation is a Comparative Effectiveness Research Center.
Right.
To your knowledge, has anybody looked at the concept of aging in place versus the other facets of elder care to see how effective it is in comparison with nursing home care or assisted living care, those types of things?
If you look at